Hello everyone, very good morning to all of you. I hope I'm clearly visible, audible. So let me confirm. Give me a second for confirmation. If I'm clearly visible, audible, I will start the lecture ahead. So yes, I hope it is working. So I welcome you all for today's session. I am Dr. Priyanka Sachdev here, and today I am here to take a session on the pathology, the GIT pathology, the gastrointestinal system pathology. So in GIT, we have to study the pathology of three organs basically: esophagus, stomach, small and large intestine. So let me start with the pathologies of the esophagus. Just a second, yeah. So let me start with the pathologies of the esophagus. So I will teach you all the diseases of possible diseases of esophagus here. Then I will come on the stomach and then small and large intestine. So one by one we will start it. So without wasting time, I'm starting with esophagus. So before starting the pathologies, you should have a overview of the anatomy and the normal histological diagram of the esophagus. So we know esophagus is a narrow tube which connects the pharynx with the stomach. So it is a tube, it is a food pipe which connects the pharynx with the stomach, and it is 25 centimeter long. We know it is 25 centimeter. So what is the starting point of it and what is the end point of it? So let me show you just a second. Okay. So here you can see, so this is, let me draw a diagram. So this is the pharynx. This is the pharynx. This is the esophagus. This is the esophagus you can see, and this is the stomach. It is opening in the stomach. Can you see? This is opening in the stomach. So it is starting. What is the starting point? Here, the starting point is C6 vertebra. It starts at C6 vertebra. It starts at C6 vertebra here at T10. This is T10. At T10, it passes the diaphragm. It crosses the diaphragm through esophagus hiatus. And at T11, it opens in the stomach at T11. So learn three levels: C6, T10, T11. These are the three main markings of the esophagus. So what are the three main markings? So you can see at C6, it is starting at the lower border of the cricoid cartilage. At T10, it is passing through the diaphragm through esophagus hiatus. And at T11, it is opening in the stomach. Done? Have you got it? So these are the three openings, the three markings you can see here, right? Esophagus have four constrictions. Okay, let me tell you the constrictions: T6, T4, T6 and T10. Okay, I would like to draw a diagram. Esophagus is not a straight tube. So there are four constrictions. So the first constriction is at the starting point. Then this is the second constriction. This is the third constriction. And finally, this is the fourth constriction. And then it is finally opening in the stomach. After this is opening in the stomach. So this is the esophagus in front of you. So you can notice these are the four constrictions in the esophagus. These are the four constrictions you should know. They are present in the esophagus. So the first constriction, it is present at C6 only. It is the starting point of the esophagus. It is cricopharyngeal junction. So it is at C6. The second constriction is at T4. The third is at T6. And the fourth one is at T10. So what is the reason of all these constrictions? The first constriction, that is T6, is the cricopharyngeal junction. The T4 is due to crossing of aorta. Aorta is crossing from here, the arch of aorta, which is compressing the esophagus at this point. So esophagus got compressed. It is due to aorta. It is due to aorta. T6 is due to left bronchus. Left bronchus crosses above esophagus from here. Left bronchus. So it compresses the esophagus at this point. So esophagus got compressed. And T10 is esophagus is crossing from the diaphragm through esophagus hiatus. So it is due to the diaphragm. So please learn, many MCQs come from this. So this is the normal things you should know. The four constrictions in the esophagus: C6, T4, T10 and T6 and T10. So it is C6, T4, T6 and T10. You should know the reason for all of them, as I have already told you. It is at the beginning, C6. T4 is due to arch of aorta crossing. T6 is left bronchus crossing, and T10 is due to diaphragm. It is due to passing of esophagus through esophagus hiatus from the diaphragm. So you can see the four constrictions in these diagrams also, as I have drawn for you the same thing. So you should know the distance of these four constrictions. What is the distance of these four constrictions from the incisor tip? Why you should know? So whenever you put any nasogastric tube, this is the nasogastric tube inside the patient, you know, sometimes we have to put the nasogastric tube in the patient. So this nasogastric tube is going inside from the esophagus. So there will be 4 times constrictions. You will feel resistance. These are the natural constrictions and you have to overcome it by just pushing it. So it will reach inside and it will reach the stomach. This is the stomach. Here you have to stop. Here you have to stop in the stomach. Can you see? This is the nasogastric tube. I'm putting from the nose. It is going in the esophagus, and just in the stomach, I have to stop it. So you should know. So there are 4 constrictions here now. So one is at the C6, then is at T4, then is at T6, and then finally at T10. So these are the 4 constrictions. So whenever you will put this tube inside the esophagus, at all 4 constrictions, you will feel 4 times resistance, a little bit resistance while pushing it. So you have to overcome that resistance. So you should be able to know these distances. So what are these distances? So either learn the distances in inches or learn in centimeter. You know the conversion. How 1 inch is how many centimeter? So inches में easy है. 6, 9, 11, 16. So learn like this. It is 6, C6 6 centimeter, 6 inch, then 9 inch, then 11 inch, and then 16 inch. So learn like this. Or you can learn in centimeters also. Centimeters में the distances 15 centimeter, 22.5, 27.5, and 40. So 15, 22, 27, it is 15 centimeter, 22.5, 27.5, and last is 40. So you can do the conversions. So many MCQs come from these distances. So you should know that you should know 3 things. The 3 things are in front of you. You should know what you should know. You should know their level, the 4 constrictions. What is the level? C6, T4, T6, and T10. You should know the reason for each of them. You should know the distance of each of them from incisor. All these distances are from incisor teeth. You know here, incisor teeth से ये चारों distances हैं. So all distances are from incisor teeth. Have you got it? Have you got it? So that is the 4 distances with 4 reasons. You can see the 4 reasons are written in front of you. C6, T4, T10, T6, and T10. T10. Have you got it? Give me a thumbs up if you got it in the chat box. So that is the thing. So these are the 4 constrictions along with their reasons, along with their distances. The next point, before coming to the diseases, you should know the layers. There are 4 layers in esophagus like the complete GIT. The innermost layer is the mucosa, then submucosa, then musculus propria, outermost is serosa, or also known as adventitia. So you can see this is the esophagus, this is the lumen of the esophagus here. You can see and you can appreciate the 4 layers. Can you see? This is the innermost layer, mucosa. So what is the mucosal lining? It is squamous cell. It is squamous lining, squamous epithelia, mucosa. You can see submucosa. This is the submucosa. Submucosa have glands. Submucosa have glands, and then muscularis propria, and then serosa. About submucosa, so mucosa, as I have already told you, mucosa is non-keratinizing stratified squamous epithelia. It is non-keratinizing. Stratified means multi-layered. Multi-layered squamous epithelia, right? So this is the mucosa. Submucosa mein there is a plexus of the nerves, that is known as Meschner plexus. Please understand this Meschner plexus, huh? And in muscularis propria also we have a plexus. The name of that plexus is Ayurveda plexus or Meintier's plexus. So we have 2 plexus. What are the 2 plexus? So here are the 2 plexus. You can see the Meschner plexus and Ayurveda. Ayurveda also known as Mentric, one and the same thing. So Meschner plexus is present in submucosa and Ayurvedic plexus is present in muscularis propria. These are the different layers. So to understand the diseases, you should know. Now let me start the diseases. You already have an overview of the anatomy, of the histology of the normal esophagus. So you will have a better understanding of the diseases now. So these 3 diseases today I will teach you in esophagus, from which maximum MCQs come from the esophagus. So the first disease is achalasia. What is achalasia? What is achalasia? Also known as cardiospasm. Now cardiospasm, it is a misnomer. It is nothing to do with the heart. Cardiospasm. So achalasia or cardiospasm. So that is the first disease. Second is hiatus hernia. Third is Barrett esophagus. So these 3 diseases are important from pathology point of view from esophagus. So let me start with the first disease, achalasia. Does anyone know what is achalasia? What is achalasia? Okay. So these are the headings under which I am going to describe this disease, achalasia. Listen. So can you see this is the esophagus? Please everyone see this beautiful diagram. This is the esophagus and this is the stomach. So the junction of the esophagus and the stomach have a sphincter. This one. It is known as LES, lower esophagus sphincter. LES. It is always closed. Currently inside me, inside you, inside all normal human beings, it is closed all the time. Whenever we eat anything, we swallow anything. Just suppose I'm eating, I'm drinking, I'm swallowing anything. So the food bolus, the food particle will go in the esophagus. In the esophagus, the food bolus particle. So whenever the wave of peristalsis is coming in the esophagus, at that time, this LES will open and allow the food bolus to go from the esophagus into the stomach. At that time only it opens. After that it closes again. So this is the normal physiology of LES. LES normally closed. So normally LES is always closed. But during swallowing, when wave of depolarization is coming, when wave of peristalsis is coming, at that time LES is relaxed and it is opened. So to allow the food particle from the esophagus into the stomach. This is normal physiology. This is normal physiology. Now, you know what is wave of peristalsis? This is wave of peristalsis I have drawn here in the wall of the esophagus. How will you describe the wave of peristalsis? Wave of peristalsis is alternate contraction and relaxation. Can you see this is esophagus? So this portion is contracted. This is relaxed. And again, this is contracted. So contracted, relaxed, contracted. Now, in the next few seconds, the portion which is contracted, it will become relaxed and the relaxed one will become contracted. So alternate contraction and relaxation will push. This is the food bolus. Can you see this is the food bolus? So it will push the food bolus ahead, 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 and finally food bolus will reach the stomach. So that is the wave of peristalsis. Now the point is that this is LES. Now I have told you this is LES. This is LES. It will open only when you are swallowing anything. So when wave of peristalsis is coming, at that time it will open. So what is causing opening and closing of the LES, or what is causing the peristalsis में contraction and relaxation? So when LES contract, it closes. When LES relax, it opens. So what is causing, which chemical is causing contraction and relaxation? So there are two type of neurons in the plexus. I have told you, no, there is Meissner's plexus, Mandrake plexus. So in the plexus, we have two type of neurons. In the esophagus, in the LES, stimulatory neurons and inhibitory neurons. Stimulatory neurons secrete acetylcholine, which causes contraction, and inhibitory neurons causes secrete nitric oxide, NO. It causes relaxation. So alternate contraction and relaxation causes peristalsis. Have you got it? Give me a thumbs up, John. Have you got it? Have you got it? So this is the normal phenomenon how peristalsis takes place, and not only peristalsis, also the normal physiology of LES. LES normally inside me. Currently, I'm not eating anything. I'm teaching you. I'm not swallowing anything. So my LES is closed because the stimulatory neurons secrete acetylcholine, which is causing contraction of LES. So my LES is closed right now. But if I eat anything, if I drink anything, at that time, NO will come in role and it will cause relaxation. So my LES will open and my food particle will go from esophagus to the stomach. Give me a thumbs up if you got it. Everyone give me a thumbs up. So this is the normal physiology. So normal physiology mein there are, just a second, let me see. Yeah, so in normal physiology, there are two things. There are two things, acetylcholine and NO. One is causing contraction, one is causing relaxation. Now, what is the problem with achalasia? Achalasia mein kya problem hai? What is the problem with achalasia? In achalasia, during swallowing also, this LES is not opening. LES is always closed. During eating, during swallowing, during drinking, LES is not opening. So food particle cannot be transmitted from the esophagus to the stomach. The food particle will gather in the esophagus only, in the esophagus. So the wall of the esophagus will dilate, and because food is accumulated, it is known as mega esophagus or sigmoid esophagus. The esophagus is looking like sigmoid colon. Mega esophagus, sigmoid esophagus, and because of the food particle accumulated in the esophagus, patient have pain during swallowing. Dysphagia is there, and there is more chances of infection in the esophagus because food is gathered, accumulated there. No, esophagitis के chances ज़्यादा है. So that is known as achalasia. Have you got it? What is the problem? LES is not opening during swallowing. It should open during swallowing, but it is not opening. So what is the definition? It is a neuromuscular dysfunction in which the cardiac sphincter, that is LES, failed to relax. It is not opening. It is failed to relax during swallowing. So it is due to the increased tone of LES. Now the problem is why. The question is why. Why it is not opening? Why it is? Normally we have both now, acetylcholine and NO. So acetylcholine causes the contraction and NO causes the relaxation. Here the inhibitory neurons are destroyed. In achalasia, the stimulatory neurons are normal. So they are secreting acetylcholine, so contraction is normal. But inhibitory neurons are already destroyed. Now, cause of destruction can be due to, it can be congenital, God has not given them, or it can be acquired. Acquired is due to the destruction of this specific neurons by a parasite. The name of the parasite is Trypanosoma cruzi. It is known as Chagas disease. So Chagas disease and Trypanosoma cruzi may these inhibitory neurons are lost, they are destroyed. So NO is not there. NO is absent. Nitric oxide is absent or it is decreased. So there is an imbalance between acetylcholine and nitric oxide. So contraction is normal, but relaxation is decreased. There is no relaxation. So LES is closed, but it is unable to open. Have you got it? So that is the problem. That is the problem. Give me a thumbs up if you got my point. So this is, can you see, this is normal esophagus, this is achalasia esophagus. So whenever we eat anything, so during swallowing, can you see ileus opens little bit and transmitting the food particle from the esophagus to the stomach. It is opening here. But see, in achalasia, it is not opening. Even on swallowing the food particle, it is not opening. So food particle will gather here only. Now compare the wall. See the wall of a normal esophagus and see the wall of esophagus in achalasia. It is dilated, it is thinned out. So that is known as mega esophagus. Or so what are the terminologies we can use here? Number one, we say it is a mega esophagus because esophagus is dilated. Number two, we say it is a sigmoid esophagus because esophagus is looking like sigmoid colon dilated. Number three, we say it as rat tail appearance on barium swallow. Rat tail. What do you mean by rat tail? Chूहे की पूंछ. So can you see it is tapering? It is tapering of the esophagus. It is tapering. So that is known as rat tail appearance, or it is known as cucumber appearance. Cucumber appearance on the X-ray. Cucumber. You know cucumber. Cucumber यानी ककड़ी. ककड़ी खाई है क्या? In summers we have this big cucumber. So it is tortuous. It is tortuous. You know the esophagus is tortuous like the cucumber. A big cucumber, large, long cucumber. So that is the cucumber appearance. So rat tail appearance, cucumber appearance. You have to learn all these appearance for your MCQs, right? So that is about achalasia. Now there is a triad of achalasia. What is the triad? There are three problems in achalasia. We have already understood. Ileus fail to relax during swallowing. Whenever we swallow anything, ileus is not relaxing. It should relax, but it is not relaxing because NO is absent because inhibitory neurons are destroyed, either congenitally or acquired. That is the problem number one. Ileus is not relaxing, so tone of ileus is increased. Tone of ileus is increased, and peristalsis is also absent because peristalsis is alternate contraction and relaxation. For contraction, you require acetylcholine, which is present, but for relaxation, you require NO, which is absent. So A peristalsis is there. So this is the triad of achalasia. I hope you got it. I hope you got it. So you can see the same thing here. You can appreciate the same thing here. So ileus is closed. That is the only problem. As I have told you, it is of two types. Primary is congenital and secondary is acquired. Congenital or idiopathic. So it is congenital mantric plexus damage. God has given damaged neurons. Which neurons? Inhibitory neurons, not excitatory. The stimulatory neurons are normal, acetylcholine is normal, but inhibitory neurons are absent. God has not given them. So NO is absent. So relaxation cannot occur. And secondary is due to acquired cause. Acquired cause is a parasite. The name of the parasite is Trypanosoma cruzi, and the disease is known as Chagas disease or sleeping sickness. It causes destruction of specifically inhibitory neurons in the mantric plexus. You know what is mantric plexus. Okay, so what are the morphological features? You can understand the esophagus got dilated. Number one, muscularis propria first gone hypertrophied and then thinned out. Due to the dilatation. And secondary esophagitis, that is supervein infections, because food is gathered here, no? Food is gathered here, so it will get dilated. It will get dilated and it is more prone to get infections. You can see this is normal esophagus, see the ileus, and this is the esophagus of achalasia. See the tortuosity. It is tortuous, dilated, elongated, tortuous. And here it is straight. Normal is straight. So compare the two. So that is the thing. You can see the tortuosity here. It is cucumber appearance. Have you got it? So what are the symptoms? Patient will come to you with symptoms. So the first symptom patient will give to you, doctor, I am having dysphagia. Dysphagia is pain during swallowing, problem, difficulty in swallowing. So patient cannot swallow the things because it is not transmitting from esophagus to stomach. So you being a doctor, the first question you should ask, you have dysphagia more for solids or liquids? So here typically, I'm sorry, in achalasia, patients have I'm sorry, patients have dysphagia more for liquids as compared to solid. Liquid के लिए dysphagia ज़्यादा होता है. It is more for liquid as compared to solids. Second is regurgitation. Regurgitation is reverse peristalsis. Food cannot transmit here, so it will come back and patient will vomit. So that is regurgitation. Patient cannot eat anything, so it is not absorbing. So he is not getting energy. So weight loss is there. Recurrent respiratory tract infection is there. Retrosternal discomfort and anemia will be there because patient unable to absorb the things. What investigations you will order? What investigations you will order in this patient for the diagnosis of achalasia? Suppose this patient is in front of you, you have a high suspicion that this patient is having achalasia. What investigations you will order? You will order one screening test and three diagnostic tests. Diagnostic tests are three. Diagnostic tests are three in number. Screening test is only one. So what is screening test? बहुत आता है ये. It is very important question. MCQ wise also, theory question also. It is known as CCK test. What is the full form of CCK? It is cholecystokinin test. Cholecystokinin test, CCK test. So there is a patient in front of me having a complaint of dysphagia. Imagine this is the patient. This is the patient. He is having complaint of dysphagia. He is having difficulty in swallowing. So what I will do, I will give him an injection of CCK. I will give the patient injection of CCK. So CCK ka injection, I don't know the patient is having achalasia or